Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. It seems everywhere I go, I hear people talking about the growing role of private equity investment in all sorts of parts of the economy. Healthcare is a big part of that conversation. Indeed, we had a recent episode on this podcast about the increased private equity ownership of dental practices, just to take one example. Now, research on the effects of private equity on healthcare prices, access, and quality is stymied in part by limited data on the prevalence of that sort of investment. But creative investigators are doing their best to overcome these limitations. Today's guest is an example of that. Our topic today is private equity ownership of hospices. I'm here with Melissa Aldridge, professor of geriatrics and palliative medicine at the Icahn School of Medicine at Mount Sinai. Dr. Aldridge and co-authors published a paper in the September 2024 issue of Health Affairs that used a novel data set to examine private equity acquisitions of hospices, and they found quite a lot of activity. We'll discuss these findings in today's episode. Dr. Aldridge, welcome to the program.
Thank you for having me, Alan.
Well, let's get right into this. Now, you focus in on two things that are probably somewhat familiar to our audience, but maybe not fully, and I just want to set the stage here. Let's start with hospice, a service that I think most of us have heard of, but maybe don't know a lot about sort of how it's provided. Can you just give a brief history of hospice, and particularly hospice ownership, since that's the focus of your research?
Hospice in the United States started in the 1970s really as a grassroots movement, and it was considered very alternative in its focus on comfort more than curative care, on the family over just the patient, and really most importantly, it was home-based care, and it was largely a reaction to people dying in hospitals of cancer in a lot of pain. And so it was founded by nonprofits, supported by donations, largely nurse-driven, taking patients into their own homes. As it grew in the United States, Medicare began coverage of hospice care in 1982 with the Medicare hospice benefit. But it wasn't until really 1989 when the Omnibus Reconciliation Act increased reimbursement for hospice by about 20% that the number of hospices in the U.S. really began to grow. So across the early 90s, we went from hospices being solely nonprofit to an increasing share of hospices that were owned by for-profit providers. By 2000, roughly 30% of hospices in the U.S. were for-profit owned, and by 2024, where we are now, 75% of hospices are for-profit owned. So really a shift from a nonprofit grassroots movement all the way up to a for-profit dominated market today with a lot of different ownership structures, chains, vertical integration, etc. So it's largely been that type of shift over time.
That's quite a story. And of course, we could tell a similar story about hospitals, which began as charities. And of course, many of them still are, but the private ownership of hospitals isn't quite as large a share as what you just described, for-profit ownership, I should say. But that transition does seem to happen in various parts of the economy. We'll come back to that. So let's just get the other piece of what you studied, which is private equity. Again, we've covered this topic various times in the podcast. But put your research into private equity ownership of hospices in the context, if you could, of broader understanding of where PE fits into healthcare.
So I think it's important to note that the growth of for-profit within hospice specifically is driven by a number of factors specific to how Medicare reimburses hospice care. It's reimbursed on a per diem basis, and so you receive a certain amount of money, roughly $200 a day for each patient receiving hospice care, and that's regardless of the amount of visits or care provided. It's also largely unregulated. So we have very few kind of quality metrics and oversights for hospices who want to participate in the Medicare Hospice Benefit Program. So for a number of reasons, it's reasonable to understand for-profit entry. Private equity has made investments in healthcare broadly, as you said, in hospitals, in nursing homes, dental practices. Roughly $90 billion of private equity was spent on takeovers in the healthcare industry in 2022. Private equity in home health and hospice, though, has outpaced any other type of healthcare services in the last few years.
So let's turn to your study in particular. You're focused, as we noted, on the acquisition of hospices by private equity firms. Tell us what you found. How much of this acquisition is going on, and what do we know about the characteristics of the hospices that are being acquired and the firms that are doing the acquiring?
So we identified 124 hospices that were acquired by 47 private equity firms between 2015 and 2022. We used a unique database called the 11Pro database that actually tracks M&A across a number of different sectors. So the majority of the acquisitions occurred between 2018 and 2022. And although most private equity firms acquired only one or two hospices, one private equity firm acquired 22 hospices spanning 10 states, and another acquired 14 hospices spanning 4 states. So in addition to acquisitions becoming more and more prevalent, what we saw was a consolidation in terms of the same private equity firms buying up hospices. There were some regional variations. We found the majority of the acquisitions occurred in the South, 52 of the transactions that we found. Very few in the Northeast, and actually none in New England. They tended to buy hospices that were larger in size in terms of the number of patients served. And also they tended to be newer. On average, the hospices were about 10 years old, but a quarter of the hospices had only been in business for 5 years or less. And so as we think about the growth of hospices across the U.S., these are ones that really came about only in the last 1 to 5 years.
So this is a pretty fast-moving marketplace, it sounds like. What led you to want to look at this in the first place?
We've spent a number of years understanding how the for-profit growth in the hospice industry has impacted the care of patients across the country. And our team, as well as a number of other teams, have found significant differences in the population served and in the care received and in the quality of care, with the predominant result that for-profits are providing worse quality of care in the United States. There's been differences in terms of having more emergency department visits, providing a narrower range of services, greater complaints, deficiency allegations. It's really fairly well established that there are these differences and they're profit-driven. And so as you think about then private equity getting involved, it's also for profit, but maybe with a greater intensity given the drive to sell the hospice over a short period of time. And so in our minds, it takes the incentives and the push that's driving care in the for-profit hospice sector even further. And so understanding that, given 50% of individuals who die in the U.S. are under the care of a hospice, it's really important to understand if this private equity wave is similar to the wave of for-profit growth that we saw a few decades ago and was really important to figure out.
So you're describing, I would say, some alarm bells going off around for-profit ownership, and you're seeing this new trend of even of a potentially more aggressive form of for-profit ownership through private equity, and trying to figure out, is this the same problem, a bigger problem, and how do we understand it? So I want to ask you a few questions to help me think about what we should have in mind from a policy perspective around these issues. We'll cover those topics after we take a short break. And we're back. I'm speaking with Dr. Melissa Aldridge. We're talking about private equity acquisitions of hospices. I was really struck. I'd never thought of it this way, but when you mentioned the fact that, of course, you're not going to change providers at this point of so much stress and duress, and we do think about sort of, well, markets should function and should solve this problem. And I know there are a lot of barriers to that in healthcare, but this barrier seems particularly a particularly high hurdle. And I don't mean this to sound morbid, but this is a service you only use once. And so it's not as if you have a bad experience the first time, there's an opportunity to say, well, next time I'll do it differently.
Exactly. There's so many characteristics, whereas private equity broadly, maybe there isn't a blanket statement on whether it's good or bad, even within healthcare. But in my mind and our team's mind, based on the evidence that we've found within hospice, there are so many specific ways in which this can be a problem. It's really important to understand. And I think the other aspect of private equity, more than for-profit ownership being concerning, is that we can't see it. We can't see that that's the ownership. And so that's one of the reasons we dove into this study, is because while Medicare can track for-profit, nonprofit, even different types of for-profit and nonprofit ownership, they don't have a great way yet of tracking this type of private equity ownership and co-ownership. So the complexity of these ownership structures are changing really rapidly, and we don't have a great way of even seeing it yet, let alone understanding its impact.
So I want to ask you about what questions we can't answer and what questions we're trying to answer. But before we do that, I want to return to something you mentioned early on, which had to do with Medicare payment. It's quite concerning to me, as someone who works in healthcare, to think that Medicare payment policy could be a driver of this deterioration in quality. Now, maybe that's overstated, and I know you didn't make a causal claim, so I'm not going to put those words in your mouth. But we've moved from this, as you say, sort of alternative movement supported by charity to the mainstream, which we tend to think, okay, that's great. It expands access. You now have Medicare coverage for this. But if there are attributes of how Medicare pays that are leading to undermining the model, that would be of great concern. So I wonder if you could just spend a little bit more time with me on, you mentioned the per diem rate. You mentioned that the bundle of services is not perfectly defined. How does that play into what private equity is looking for? And just from a policy perspective, are there things that maybe Medicare could do a little differently to reduce that risk?
When hospice started, and it came in, as I said, in a very unique way. And one of the things about it is it's a very comprehensive service. You can get pain and symptom management. You can get counseling. You can get bereavement support for your spouse. So a whole range of services. So the payment model of a per day, no matter what services are provided, made sense for something like that, because you're supposed to figure out what that patient and family need in the home and provide it, and then you're given your per diem amount. You can see, though, that if that's not monitored, then you also have a situation where providers are getting paid and not doing anything for a patient. And so there was a lot of research about that. How many patients in their last week of life were not visited by anyone from the hospice? And so that has slowly changed over the past, probably 7 or 8 years, 2016, when they kind of changed so that you had differential rates in the last days of life, so that we tracked visits in the last week of life. And so there has been an attempt to modify both the payment policies as well as some of the oversight to address this. But the incentives are still there. And some of that plays out in terms of for-profit providers, and the very little evidence we have so far about private equity kind of cherry-picking patients, enrolling patients who may not need services and will be in hospice for a long time, so that you can rack up a lot of the per diem payments over time for that individual person. And so those incentives are still very strong, although Medicare has tried to address them in some ways.
I do have to say, this is a cautionary tale for the movement to capitation. And people always say, fee for service is the root of all evil. But the incentives for taking a steady flow of dollars, which is what a capitation payment is, and finding a way to make a lot of money off that without providing enough services, those incentives are very strong. And we have lots of stories from history of bad actors figuring out how to capitalize on that, and people really suffering for it. And so it's a reminder that although there are great opportunities for flexibility and delivery system improvement when you move away from fee-for-service, without appropriate monitoring and quality standards, it is also an opportunity for the kinds of things you describe, and we should not forget that. So I have to say, listening to you, your concerns here are quite substantial, and they're also evidence-based. So I don't. It's a good combination. But as you've noted earlier, we don't have a lot of information. Ownership models are quite complex. So I think as we bring our conversation to a close, I'm interested in sort of where do you go with this? Okay, you've made an investment here in trying to figure out the ownership structures, which is not easy to find. How do you take that information and what questions do you ask? How do you combine it with other types of information to get at what I think is the question that you outlined earlier, which is we have reason to think that for-profit ownership is of concern. We need to understand if private equity exacerbates that concern. So how do you approach figuring out whether or not that's the case?
So I think that there's two things. I think that as researchers and policymakers, we need to be creative in using the different data resources that we have to understand these complex ownership structures, because it doesn't make sense anymore to just be comparing for-profit and nonprofit or kind of chain ownership or not. These structures have gotten far more complex. And although Medicare has done some work, there's a new database called a PICOS database that tries to track ownership and requires hospices to report if they've had a change in ownership. But whether that's reliable and complete is unknown. So thinking about some of these other data sets, like the 11 Pro data set we had, that really can get at the ownership, the consolidation, these more complex structures, so that we can understand its impact on patient and family outcomes is really important. And I also think that as we consider what the impacts might be, we should think about the types of patient groups who are not profitable. Because the profit motive in hospice, in healthcare, it's not going away. It can be kind of driven towards the outcomes that we want. But we have to think about, what if you're the patient who needs hospice, who's clearly not going to be profitable? They need a lot of care in that days per diem. And we need to make sure that they are going to continue to have access to high quality care, no matter what those incentives are and how complex the market gets.
Again, a reminder that capitation requires a certain approach to risk adjustment, that you need to make the payments aligned with what the needs of the patients are, even if you aren't doing it at the fee-for-service level of counting widgets and visits, and the complexity of services in hospice makes that a not very appealing approach. We still need to acknowledge, as you say, that there are some people who need a lot more services than others. And if everyone's getting the same amount of money for everything, then or I should say, if everyone's getting the same amount of money for every person they serve, then those incentives are going to be quite distorted. Well, I really appreciate you describing the approach you took, and I have to say you've raised quite an alarm for me. I've always known that there were risks around the hospice benefit, but this adds another layer. And it also does suggest that all of us in healthcare need to become a little bit more savvy about the finance, and particularly, as you note, the data sources related to finance, which are not the ones that health services researchers typically look at, but that could provide us with very important insights. Otherwise, we're just not even going to be able to answer these questions, much less develop policies that respond to them. So I guess I just want to close with a question of, what do you see coming next year? Do you think that if you look again more broadly at some of the concerns around private equity, do you see a way to target the ownership side, or is it really just looking at the payment and quality side?
I think we have to focus on the access and quality side and see if there really is an impact for patients and families. And so I think it takes understanding these structures in a more complex way. So we haven't even touched on the fact that private equity ownership can be in certain proportions. You can own all of a hospice or maybe a 20% stake or a 60% stake. Does that really matter for outcomes for patients and families and for access? And so I think taking what we did the next step further, which a number of teams are trying to do, and linking this to the outcomes experienced by people in the U.S. under the hospice benefit, is the next step in trying to understand what we could do about it, if anything.
Well, Dr. Aldridge, thank you so much for explaining this complex subject, for adding to our understanding of this important issue. I appreciate having you today as my guest on a Health Podyssey. Thank
you very much, Alan. It was great to be here.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about a Health Podyssey.